So welcome to this video or podcast if you're listening along. This is part of the EGP Learning PCN DES guidance series for 2021. In the series, we're looking at some of the key policy documents for running primary care networks and giving you a good overview of these documents. Today, we'll be focusing on the Structured Medication Reviews and Medicines Optimization guidance that was published on the 31st of March 2021. The purpose of this video or audio recording is to help you understand the structure and content of the document. It's a good way to absorb these documents and get an overview of the contents if you're doing the ironing or driving your car, going for a run. It's great to put these on, and then it makes the documents a little less daunting when you actually finally need to pick them up, and also gives you an overview of what's actually in them if you need to dig something out and answer a specific question that's coming up within your primary care network. As ever, little disclaimer, I'm not an expert, I am not a commissioner, I am not your commissioner. So if there's any specific questions about how those of us designing and implementing services are going to actually deliver and structure these services, have those with your local commissioners just to make sure that you're actually ticking all the right boxes for them and that you will meet your contractual requirements and be able to draw down any funding associated with those. So without further ado, let's dive into the document. As ever, we scroll through the documents. I've annotated it in advance and we'll spend some time on what I think are some of the key points. So always with a little look at the contents page, gives you an idea of the structure of the document, and for the purposes of this video and audio recording, it gives us an idea of what we're going to cover as we go through the document together today. So we'll spend really most of our time with each of the service requirements, 1 through 7, and then I'll just talk you through what's in Annex A and Annex B, as there's lots of sort of additional information and links to other tools and resources that might be helpful. So let's scroll through. We'll spend a little bit of time actually in section 1, which is the purpose. Really, all to mention here is that this guidance is supplementary to the other guidance provided within the main network contract specifications and network contract DES guidance, so should be read in conjunction with those. So in section 2, which is the introduction, it just talks about SMRs in general and really just reminds us that the Structured Medication Review is an evidence-based intervention that should be focused on complex and problematic polypharmacy. It's an intervention that is holistic and specifically includes shared decision-making conversations. This section also talks about, so why are we doing SMRs as primary care networks? Why has this been an intervention that's been chosen to be focused on by all of us? And that is because the feeling is that there's a big opportunity to make a difference both to patient outcomes and to liberate funding and avoid waste within the NHS. So they've identified that actually there's up to £400 million spent annually on unnecessary admissions to hospital that are related to harms done through medicines misuse or medication-related issues. And also it's highlighting that actually there are other potential gains in the area of better value for money around prescribing, reducing waste, reducing carbon footprint. So there's all sorts of reasons why we should be focusing on SMRs. And the other thing that isn't really directly alluded to in the document, but whilst £400 million is spent annually on medication-related issues and admissions to hospitals, I'm sure that polypharmacy and incorrect or unoptimized use of medications actually waste a lot of resources in primary care as well. And there's something to be said about proactively making sure that our prescribing for patients who are at risk of prescribing issues is really, really good. So I think it's a good intervention, and I'm on board with SMRs. So let's continue to move through. So the next section just talks about what provisions are available to support PCNs. And I think that's something to read into if you're interested. But in terms of the implementation, there's nothing too significant there. So section 3. So this is the meat and bones of the document, really, where we go through each of the 7 service requirements. So section 3, guidance to support implementation of the service requirements, essentially. So Section 1 talks about the identification of patients, and it highlights the certain groups of patients which it is stated that PCNs should and need to focus on and prioritise. So these are patients in care homes. All sorts of ways to do that, and I'm sure there's ways to integrate that with the work that primary care networks will be already doing as part of the care home element of the primary care network specifications. People with complex and problematic polypharmacy, so it specifically identifies the figure of 10 or more medications to focus on. Also, on medicines commonly associated with medication errors, and I would say particularly harm associated with medication errors as well. So I think DMARDs, DOACs, and other similar medications are really fair game. Those medications that require additional monitoring to be delivered safely, I think would fall into that category. A focus on those with frailty and a focus on potentially addictive medications, particularly identifying opiate painkillers, your gabapentinoids, benzodiazepines, Z sleeping drugs as well. And we should be making an effort to really focus on those groups, and that's coming through quite strongly in the wording of the specifications. Also says that there are additional groups of people where capacity allows that we might want to stretch to include as well, and that's covered in section 3.2. Section 3.3 just highlights that in Annex B, which we'll get to at the end of the document, there are a number of tools that are linked to help with the proactive identification of patients in this group or who would benefit from structured medication reviews. Also mentions that and encourages support and collaboration from the CCG and the medicines management teams within CCGs. So I think if PCNs aren't linking in with their medicine management teams, who are generally funded through the CCG, then this is a little nudge to do that, and also to highlight to the medicines management team that actually NHS England are keen for collaboration. Special mention for the Pincer Tool. I'm sure we've all actually spent a lot of time with that over the last few years as well, but that's specifically mentioned within the main body of the text as something that can be used to identify patients for structured medication reviews. Section 3.6, it's also suggested that, or in fact, we're told that PCNs should develop a process for proactively identifying rewind slightly. We should have a process for reactively identifying patients as well. So these are patients who, because of some sort of incident or some trigger that can't be proactively anticipated, would benefit from a structured medication review. And we should have processes in place to identify these patients as well. So this is really about setting up routes for these patients to be referred in for medication reviews. So this is where something happens, a crisis, an incident, a hospital admission. Can we pick up those patients and offer structured medication reviews where there's personal concerns from the patient or a carer, or where a professional thinks that it would be helpful for someone to spend more time going deeper in with their medications. I think these sorts of systems, particularly being reactive to personal and professional concerns, should be fairly easy to provide a route into SMRs. I think we need to think a little bit more carefully about how people are flagged up post-admission as well. And then also, if the system or professionals think that there needs to be some dosage titration or some attention to a particular medication where that touches on the issue of polypharmacy, then that would be a group to identify reactively as well. Service requirement 2 talks about prioritization and capacity, and opens up by telling us that PCNs really need a system to prioritize and manage case loads. So I think this is something that I need to take back to work on at my PCN, really. My interpretation is that we will be aware of people who are waiting for SMRs, so some sort of caseload or waiting caseload, and we need to have a way of prioritizing within that, so allowing the order in which people are called to be modified based on need. So I think people need to think carefully about that. I mean, that might look like a list of people who are due, who are safe but due for optimization through proactive identification and allowing people identified reactively to jump that queue if the person putting them into that work stream feels that is necessary. That's the sort of thing that might be put in place fairly simply to satisfy this component of the DES, in my opinion. Section 339 answers the question for us about how many SMRs we should be doing in our primary care networks, and it clearly states that the number of SMRs can be limited by the capacity within the primary care network, so the number of clinical pharmacists. It also acknowledges that clinical pharmacists won't spend all of their time doing SMRs, so their other duties can also be taken into consideration, but that conversation should take place with commissioners to identify what they feel is a reasonable number and volume of SMRs to be taking place in a primary care network, taking into account these considerations. It doesn't say whose responsibility it is to initiate that conversation. So I think PCNs might want to reach out to their CCGs, but also CCGs may want to reach out to their primary care networks in order to start to have these conversations. It's interesting, I think, to contrast this with the social prescribing requirements that are set out with the Impact and Investment Fund document, which does place a number of or a percentage of the population of the primary care network that is expected to receive social prescribing referrals. I think that's interesting because the capacity of social prescribers is also limited by the ability to recruit these individuals to work in that role. So I think it's interesting that they've taken a different approach here with structured medication reviews. So the next section goes into detail about what is a structured medication review. And I think this is a really helpful section actually, because what is in a structured medication review and how long a structured medication review might take has been a little bit of an issue at times within my primary care network. ANPs and GPs have been doing medication reviews for years, and they often do this quite quickly and efficiently and within consultations where they're dealing with other things, so they can look at the amount of time and the expectation of how long a structured medication might take for a clinical pharmacist, and that difference can cause tension within the primary care network. So I think this is a helpful section to encourage people to spend time with actually and to refer to. So what is an SMR? And I'm going to read this out actually. It's a structured, holistic, personalised review of an individual who is at risk, so has been identified as being at risk of medicines-related problems because of their current medication regime. And it clearly states that it's not the act of reauthorising repeat prescriptions or a review of some of the medications, which I think is what happens often when opportunistic medication reviews are done by other clinicians as part of their normal working life and week in clinics. Section 3.11 specifically talks about how long a structured medication review might take. And it says often more than 30 minutes in view of the complexity, but also suggests that PCNs should allow flexibility in the appointment length for SMRs, depending on the complexity of the individual case. So I think there's an acknowledgement that some may take less than 30 minutes as well. So we have a situation where some may take more, some may take less. So it might be argued that actually allocating 30 minutes on average for properly selected SMRs of properly complex patients would be appropriate. Section 3.13 just confirms to us really that they can be undertaken face-to-face, they can be undertaken remotely where deemed properly, and I think we're deemed appropriate, and I think we've been doing a lot of remote SMRs over the course of the last year, so it just confirms that that's appropriate and that we were appropriate to have done that. And also that it can take place during extended hours appointments. So I think that's probably a green light to use extended hours and extended access capacity to deliver structured medication reviews where this is appropriate for the service and appropriate for the patients. And finally, it just highlights that SMRs may not be a one-off exercise and there may be a requirement for follow-up. section 3.15. So this is where we go into detail about actually conducting the SMRs and what components are there. This section opens with a statement that I think is really designed to highlight that the principles they give below are very evidence-based, they're robust, and that there's been involvement of NICE and the Royal Pharmaceutical Society and other bodies in designing this approach. And also links to evidence to that effect as well, which people can go deeper on if they want to. So the main principles are shared decision-making should underpin the conversation. So there should be a shared decision-making conversation about medicines, management and prescribing. They should be personalised and tailored to the patient. There should be a clear consideration of safety and the risk-benefit of medications where appropriate. There should be consideration of the effectiveness of prescribing where appropriate. So I think this is where grey drugs, over-the-counter available drugs, can be addressed, and there can be a thoughtful conversation with the patient about potentially removing those items from the script, provided that that's appropriate. So all of those components are important, and I think we can see if you go actually deep on those components with a lot of individual medicines being prescribed, that's actually quite a significant undertaking, and there's significant benefits and opportunities to make improvements there. And finally, just highlighting that, there might need to be follow-up. Our pharmacists might need to go away and ask questions. There might legitimately need to be a check-in on a change after an interval period of time. So it's important that the clinician conducting it arranges appropriate follow-up, and also that their structure and working pattern is designed so that they have the ability to do that themselves. So I think appointments for reviews available for clinical pharmacists to book into feel like a good idea. The next section talks about the issues around invitations and communications. So just to spend a little bit of time with this, this is highlighting that there should be a system for structured invitations to go out to patients. I think actually, so in our primary care network, we have a system where those people booking have a script that just touches on these key points that are important, and also sends out a text or potentially provide them with some written information that can just make it clear about these points, and that these are important really for the patient to get the most out of the medication review as well. Those key points are: the invitation can be oral or written, so it can be a verbal invitation. They should explain what the SMR will involve, specifically that they are coming for a shared decision-making conversation to review all of their medications. The purpose is to make sure that they're working well for them. It would be helpful for them to bring their medications, or at least if it's remote, have their medications easily to hand to refer to during the appointment. And they should be encouraged to actually prepare for the structured medication review and have some time to prepare for it by considering what questions they might like to ask about their medications or health. And it's also highlighting that patients can, where appropriate, be supported by carers or family members. The next section, service requirement 4, just confirms the qualifications and training of those people who will be conducting structured medication reviews, and it just highlights that they need to be appropriately trained, and they actually consider a clinical pharmacist, ideally with a prescribing qualification and advanced assessment history taking skills, should be conducting these medications. And it says, or be enrolled in a current training pathway. So people who already have those abilities can be conducting structured medication reviews, but actually those people who are enrolled on the pathway, so perhaps a non-prescriber who is at least enrolled on the approved pathway, can be conducting these reviews. It also highlights that GPs and suitably qualified and experienced advanced nurse practitioners could be doing these reviews as well, as long as they're conducted according to the specifications. It just highlights the specific role here of the specific PCPEP pathway, primary care pharmacy educational pathway. I know all of our clinical pharmacists are involved on that pathway. I'm scrolling down and moving on to the next section, which talks about recording of the SMRs on the GPIT system. This is really short, and it just highlights that there are specific SNOMED codes associated with SMRs. It encourages us to use those, and it links through to documents where those specific codes are provided. Service Requirement 6 talks about collaboration on wider medicines optimization. The first section actually just highlights something which might feel like common sense, but I think it is important, and that's that they should have the opportunity to share their expertise and the lessons that they've learned with the rest of the prescribing team, including the CCG Medicines Management team. And I think a really helpful way to meet this requirement is to invite the PCN clinical pharmacists along to annual or perhaps more frequent medicines management meetings that already take place between practices and CCG Medicines Management teams. Those are places where all of these key things are routinely discussed, and I think it's really important that we get the CCG pharmacists along to those meetings. So that's to just make sure that they're collaborating on antimicrobial stewardship, medicines that can cause dependency, use of metered dose inhalers, big issue in terms of the cost of those inhalers and the carbon footprint of those inhalers, and other nationally or locally identified medicines priorities, and focusing on reducing use of medicines of low priority, low effectiveness. Bashing forwards and onwards to Service Requirement 7. And this talks about really just collaborating with community pharmacists on the new medicine service, which is something that they're involved in implementing. I think a good way to collaborate with local pharmacists are to find out who the local pharmacy committee, so that's the pharmacist version of the local medical committee, the LMC, that we're all familiar with. They have all been either encouraged or required to appoint a PCN rep for each area associated with the local pharmacy committee. So that would be a really useful individual to engage with, or to get your pharmacist to engage with, or just get your pharmacist going around doing a road trip to the local pharmacies, and starting relationships with them around this issue, which is a requirement. But I think there are so many other ways in which we can collaborate now and in the future with community pharmacists. So I think that's really, really important. So that's actually brought us to the end of the main body of the document. The final two sections are the annexes, and I'll briefly describe the content of those. Spend more time with them as and when you need to, and these really point you in the direction of helpful resources that will be useful when implementing all of the requirements of this document. I'm just going to talk through and articulate what is within these sections, just in case you're listening or watching, just so that you know what's in them and you can refer to them as you need to. Annex A is looking at further information PCNs may wish to consider, very general title. So directs us to NHS Community Pharmacy Consultation Service, NHS Community Pharmacy Discharge Medication Service, resources and information around health literacy. Just highlights, this next section is really useful actually. So it talks about brief advice and interventions on public health issues, and there's a link associated with each of these to help your pharmacist deliver short but evidence-based interventions in the areas of smoking, falls and frailty, physical activity, weight management, and alcohol reduction. So I think that's really helpful. And then Annex B talks about or gives examples of tools for the identification and analysis of patients that might benefit from SMRs. And there are the usual suspects in here. So talks about using the tools embedded within your general GPIT clinical systems, System 1, EMIS, Vision, etc. Gives links to information around NHS BSA polypharmacy prescribing sort of comparators and websites that do that function. Again, another mention for Pincer, which I think we're all quite familiar with and is a really, really useful tool. If you're not familiar with it, then look into it. Prescribing QIP improvements and audit tools. The Open Prescribing website, which, really, really good prescribing information by area. You get really good granular information, and then clinical practice research data link, which is not something I've spent time with, I don't think, actually. So maybe I need to look into that. So that brings us to the end of our review of the Structured Medication Reviews and Medicines Optimization Guidance 2021 for primary care network up and down the country. So a few final reflections. So SMRs are a complex evidence-based intervention, which is different to the types of ordinary medication reviews, which we might have been doing as an add-on to normal appointments already in general practice. I think this document and video can be helpful to calibrate expectations of the whole team around what an SMR involves, and more specifically how long they can take. I think that might be helpful in reducing friction within teams where that's arising about the length of SMRs. And implementation of this guidance is complex, and I think that PCN clinical directors and PCN senior management teams really need to consider appointing or delegating this work to perhaps the whole pharmacy team, perhaps identifying a lead pharmacist within that team to make sure that that team is ticking the boxes and meeting these requirements, or identify a non-pharmacist lead clinician to guide the pharmacist in the implementation of this work. So that brings today's video to a close. Thanks for staying with me to the end. Hopefully this has served as a really good introduction to these documents. Please go back and deeper into the documents to explore the information in more detail where that's necessary. Check out the other videos that have been looking at the updated and existing primary care network specifications, particularly if you're a PCN clinical director or otherwise involved in the business of primary care networks. Thank you very much for watching. Please like, share this with your team. You know, if that's going to be appropriate, that'd be fantastic. Someone shared one of our videos with someone who applied for a job with our primary care network. They interviewed and did very well, and then they said afterwards that actually someone had said watch a video, so it was interesting. They were able to tick all of my boxes, so that's fun. In any case, thanks very much. Enjoy the rest of your day, and goodbye.